Before this video is over, more families will hear a word they never wanted attached to someone they love: dementia. And in some of those cases, the story will be blamed on age long before anyone asks a much harder question. Was it only aging, or was a medication quietly making the damage worse? I'm Dr. Michael Hardee, and I want to talk to you about something most people never think to question until memory starts slipping, names start disappearing, and everyday tasks suddenly feel heavier than they used to. I have seen people go from sharp and independent to foggy and uncertain, and too often everyone around them assumes that is simply what getting older looks like. Sometimes it is not. Sometimes the brain is reacting to something sitting in a pill bottle, something prescribed with good intentions, something bought over the counter, something that looked completely harmless. Today, I'm walking you through 9 popular medications and medication patterns that have been linked to memory problems, confusion, or a faster slide in thinking, especially in older adults. We're counting down from the ones people underestimate to the one I worry about most of all. And stay with me for number 3, because it is often treated as a routine solution for emotional health. Yet compared with similar options, it can carry a hidden burden many seniors are never warned about. One important thing before we start. This is not a reason to panic, and it is not a reason to stop any medication on your own. Some of these drugs are absolutely necessary for some people. The goal is not fear. The goal is awareness, because you cannot protect your brain from a risk no one ever explained to you in the first place. And while you're listening, tell me this in the comments. How old are you, and how many medications do you take every day? Prescription, over-the-counter, all of it. Because the number itself matters more than most people realize. Let's start with number 9. Number 9 is diphenhydramine, better known as Benadryl, and just as important, every PM product hiding the same ingredient under a different label. Sleep aids, nighttime cold medicine, some allergy products, even some pain relievers marketed for bedtime can all contain it. That is why this one fools so many people. It feels familiar, cheap, ordinary, safe enough to leave in a kitchen drawer for years. But diphenhydramine is strongly anticholinergic. That means it blocks acetylcholine, one of the key chemicals your brain uses for attention, alertness, and forming new memories. Younger brains may bounce back from that hit more easily. Older brains often do not. That is when people start saying things like, "I just feel off," or "I can't think as clearly the next day," or "I keep losing the thread of the conversation." The drug that helped them fall asleep may be making it harder for the brain to stay sharp. What makes this one dangerous is repetition. One bad night becomes 2. 2 becomes every night. Months turn into years. And because it was never prescribed in a white coat exam room, many people never mention it to their doctor at all. They report the brain fog. They report the forgetfulness. But they forget to report the pink pill on the nightstand. If diphenhydramine is part of your routine, especially for sleep, that deserves a serious conversation. In older adults, what looks like a simple bedtime habit can become a steady drain on memory and attention. Read the label. If it says diphenhydramine or doxylamine, do not assume over-the-counter means harmless to the brain. Number 8 is the reflux medication that millions take so routinely they barely think of it as medicine anymore. Proton pump inhibitors. Omeprazole, esomeprazole, lansoprazole. These are the drugs people reach for when heartburn becomes part of life. And for some, they are genuinely helpful. But the longer they stay on board, the more important it becomes to ask whether the benefit still outweighs the cost. Now, I want to be careful here, because the evidence is mixed. Some studies have found a link between long-term PPI use and higher dementia risk, while others have not. But even when the dementia data are debated, there is another problem that is not debated nearly enough. Long-term acid suppression can contribute to low vitamin B12 and sometimes low magnesium too. And when B12 starts dropping, the brain can pay the price. That matters because B12 deficiency can look frighteningly similar to cognitive decline. Confusion, fatigue, poor concentration, numbness, memory trouble. A person can feel like they are aging overnight, when part of the problem may be nutritional fallout from a medicine they never expected to affect the brain at all. This is where people get trapped. They start a reflux pill for a clear reason. It helps. Then they never revisit it. Years later, they are still taking the same dose with the same automatic refill, and no one has checked whether they still need it, whether the dose could come down, or whether their B12 needs monitoring. If you take a PPI every day and have been on it for a long time, do not stop it abruptly on your own. But do ask whether it still needs to be daily, whether there are lifestyle changes that might reduce your dependence on it, and whether your doctor should check for deficiencies that can affect thinking. Number 7 is one that many older adults are handed for a problem that can feel embarrassing, exhausting, and impossible to control: overactive bladder. The name you may know is oxybutynin, and this class deserves attention because it sits right in the overlap between comfort and cognition. Oxybutynin works by calming bladder muscle activity, but it often does that by blocking the same acetylcholine system the brain depends on for memory. In other words, the medication may quiet the bladder while also putting pressure on the mind. And in older adults, that trade-off can become expensive. People do not always notice it all at once. They notice they are more forgetful than usual. They feel slower. They walk into a room and cannot remember why. They lose words they used to grab easily. Family members call it normal aging because the change is gradual. But if the medication causing it was never suspected, the pattern can continue for months or years. This is one of the reasons medication reviews matter so much in seniors. A drug can be doing exactly what it was prescribed to do and still be taking a toll somewhere else. Oxybutynin has been singled out repeatedly because of its cognitive side effects, and some experts consider it one of the bladder drugs most concerning for older adults. The good news is, this is not an all-or-nothing conversation. There may be other options, including non-drug strategies, pelvic floor approaches, scheduled voiding, or alternative medications that do not carry the same anticholinergic load. But none of that happens unless someone first connects the bladder prescription to the memory complaint. Number 6 is a category people often think of as rescue medication: benzodiazepines. Xanax, Ativan, Klonopin, Valium. The names are everywhere because the problems they treat are everywhere too: anxiety, panic, insomnia, restlessness, even acute stress after a crisis. And at first, these drugs can feel like relief itself. The mind stops racing, the body unclenches, sleep comes faster. The problem is what happens when short-term relief quietly becomes long-term dependence. In older adults, benzodiazepines are strongly associated with sedation, slowed thinking, poor balance, falls, delirium, and persistent cognitive dulling. Some studies have also linked longer use to higher dementia risk, though researchers still debate how much is the drug and how much is the condition being treated. What is not debated is that these medications can absolutely cloud the brain. People describe feeling disconnected, less sharp, less like themselves. New information does not stick the same way. Attention becomes patchy. Reaction time slows. And because the medication reduces distress, many people do not realize how much it is flattening everything else. The trap gets worse because the longer someone stays on a benzo, the harder it can be to come off. Stop suddenly and you can trigger rebound anxiety, insomnia, agitation, even dangerous withdrawal. That makes the pill feel essential right when it may be causing some of the very problems the family is worried about. So hear me clearly on this one. If you or someone you love has been taking a benzodiazepine regularly, do not stop it abruptly. Ever. This has to be discussed and tapered properly. But if the goal is long-term brain health, especially after 65, this is a class that should never remain on autopilot. If this is already making you think about someone in your family, tap the like button and stay with me, because the next 3 are where a lot of people start connecting the dots. And tell me in the comments how many total medications you take in a day. Not because the number is a contest, but because every extra drug raises the chance of interactions, overlap, and hidden cognitive burden. Number 5 is amitriptyline and the older tricyclic antidepressant family. This one is especially sneaky because many people taking it are not taking it for depression at all. They may be taking it for nerve pain, migraines, chronic headaches, poor sleep, or irritable bowel symptoms. That is exactly how it slips under the radar. Amitriptyline is another medication with strong anticholinergic effects. So again, we come back to the same vulnerable system, acetylcholine, the chemical the aging brain needs to stay mentally agile. When a drug blocks that pathway hard enough and long enough, memory and concentration can suffer. And because the dose may be small, people assume the risk must be small too. That is not always true. This is one of those prescriptions that can quietly become a background drug in someone's life. They take it at night. It helps one symptom. No one revisits it. Months later, maybe years later, they are complaining of brain fog, poor focus, dry mouth, constipation, daytime grogginess, and memory slips. The connection is rarely obvious unless someone knows to look for it. What makes this class particularly important is cumulative effect. Amitriptyline by itself may be a problem. Amitriptyline on top of Benadryl, bladder medication, and a nighttime cold remedy can become a much bigger problem. The brain does not experience those exposures separately. It experiences the total burden. If you take amitriptyline, this is not a cue to throw it away. It is a cue to ask whether it is still the best option, whether the dose is still necessary, and whether there is a safer alternative for your specific problem. Number 4 is the group I want families to watch carefully in nursing homes, hospitals, and even outpatient care when behavior changes enter the picture. Antipsychotic medications, quetiapine, risperidone, olanzapine. These drugs were developed for serious psychiatric conditions, but in older adults they are sometimes used for agitation, aggression, sleep, or confusion. And this is where things get emotionally difficult, because families are often scared and exhausted by behavioral symptoms. They want peace. Staff want safety. Everyone wants the situation to calm down. But these drugs can heavily sedate the brain. In some patients, they dull emotion, flatten engagement, slow movement, and reduce responsiveness so much that loved ones feel like the person is disappearing in front of them. Antipsychotics also carry serious warnings in older adults with dementia, including increased risks related to stroke and mortality. That does not mean they are never appropriate. Sometimes they are used because the situation is dangerous, and sometimes they truly are necessary. But they should never be treated like casual convenience drugs for a restless older adult. What disturbs families is how often the decline gets misread. A person starts a new medication and within days or weeks seems more withdrawn, less verbal, slower, more confused. People assume the disease suddenly advanced. Sometimes it did. Sometimes the medication is magnifying what the family is seeing. If you are caring for someone on an antipsychotic, ask directly why it was started, what symptom it is targeting, whether non-drug approaches have been tried, and how often the need is being reassessed. Those questions matter because once a sedating drug becomes part of a routine, it can stay there long after anyone remembers why it was added. Number 3 is the one I told you to watch for. Paroxetine, also known as Paxil. This matters because many people hear SSRI and assume all drugs in that family are basically interchangeable. They are not. And in older adults, paroxetine stands apart for a reason. Compared with several other commonly used SSRIs, paroxetine has stronger anticholinergic activity. That means even though it is often viewed as a standard medication for depression or anxiety, it can carry a cognitive downside that other options in the same broader category may not carry to the same extent. This is why it appears on medication caution lists for seniors. The danger here is subtle. A person starts treatment hoping to feel steadier, calmer, more functional. Over time, however, attention may feel weaker, short-term memory may feel less reliable, mental sharpness may not return the way they expected. And because mood symptoms themselves can affect concentration, the medication's role may be missed completely. This is one of the most important ideas in the entire video. When a safer alternative exists in the same general treatment lane, that is where review becomes powerful. If an older adult truly needs help for anxiety or depression, the answer is not to suffer in silence. The answer is to ask whether the current drug is the most brain-friendly choice available. Paroxetine is not a drug I like to see left unquestioned in seniors. If it is helping, that matters. But if memory complaints showed up after it entered the picture, or if there were already concerns about cognition before it started, this is absolutely worth revisiting with the prescriber. Number 2 is not just one drug, it is a whole cluster of medications people use to sleep, calm down, or take the edge off. And the reason it lands this high is because so many of them get stacked without anyone saying the word sedative out loud. Prescription sleep pills, muscle relaxers, certain anti-nausea drugs, some anti-seizure medications, some opioid pain medicines, and then alcohol on top of that at night. What happens then is not always dramatic. It is not always an overdose. More often, it is a quieter erosion. Morning grogginess, slowed thinking, poor balance, missed doses, confusion, worsening attention, a fall, a hospital trip. Then suddenly the older adult who is managing at home is in a spiral no one can explain. Families often think of medications one by one. The body does not. The brain does not. The brain experiences the sum of all the sedation, all the slowed reaction time, all the interference with normal signaling. And when that happens repeatedly in an older adult, it can look exactly like the beginning of something far more permanent. This is why the words "as needed" do not always protect people. If several different medications each seem harmless alone, but all have drowsiness or confusion as side effects, the combined effect may be far stronger than anyone expected. Many cognitive crises in older adults begin not with a disease that appeared overnight, but with a pileup of substances that all nudge the brain in the wrong direction. If you want one habit that can truly protect an older brain, it is this. Every time a new medication is added, ask what it does to alertness, what it does to memory, and how it may interact with everything already in the cabinet. And that brings me to number 1. The most overlooked risk of all, and the reason so many people never figure out what is happening until real damage has already been done. Number 1 is cumulative anticholinergic burden and polypharmacy. Not one pill, not one doctor, not one refill. The combined effect of several medications, often prescribed by different people for different reasons, over many years, all pushing the same vulnerable brain systems in the wrong direction. This is the hidden driver behind so many cases of medication-related memory decline. A sleep aid here, a bladder pill there, an older antidepressant at night, an allergy medication during the day, maybe something for dizziness, maybe something for nausea, maybe a cold remedy during the winter. No single bottle looks like a smoking gun, but add them together and the burden climbs. And when it climbs high enough, the older brain can start to struggle in ways that look terrifyingly familiar. New memory weakens, focus shrinks, processing slows, confidence drops. People withdraw because they know something is wrong even if they cannot explain it. Families start whispering about dementia. Sometimes they are right, but sometimes the first and most urgent diagnosis should have been medication overload. This is where hope comes back into the picture, because drug-related cognitive decline is one of the few things that can sometimes improve when you catch it early enough. Not always, not completely, but often enough that it is worth taking seriously. I have seen people feel clearer after the burden came down, more awake, more present, less lost in the middle of the day. Not because a miracle happened, but because the brain finally got a break. So here is what I want you to do after this video. Get a complete medication review. Not a quick glance, a real review. Every prescription, every over-the-counter product, every sleep aid, every allergy pill, every supplement. Bring the actual bottles if you have to. Ask one simple question. Which of these can affect memory, concentration, confusion, or dementia risk in someone my age? If you are a caregiver, this matters even more. Do not assume every symptom is just the disease. Sudden worsening deserves investigation. New confusion deserves investigation. A steeper drop after a medication change deserves investigation. You may not be looking at inevitable decline. You may be looking at chemistry. That is why this topic matters so much. Because people fear dementia as though it arrives from nowhere, when sometimes there are clues long before the diagnosis. Sometimes those clues are in behavior. Sometimes they are in balance. Sometimes they are in attention. And sometimes they are sitting in plain sight on the bathroom shelf. I'm Dr. Michael Hardee, and if there is one message I want you to take from this, it is this. Never let a medication become invisible just because it has become familiar. Familiar drugs can still cause harm. Routine refills can still carry risk. And the earlier you question what may be clouding the brain, the more you may be able to protect. Now, I want to hear from you. Which of these medications are in your cabinet right now? Have you ever noticed more brain fog, more confusion, or worse memory after starting something new? Put it in the comments because your story may help someone else recognize a pattern they were about to ignore. And if you know someone over 60 who takes several medications a day, send this to them now. It could start a conversation that changes everything.